It's my pleasure to introduce Dr. Brad Anawalt to speak at Medicine Grand Rounds this morning. Dr. Anawalt is a professor and vice chair of medicine in the Department of Medicine and serves as the chief of medicine for the University of Washington Medical Center. Dr. Anawalt earned his medical degree from the University of California at Davis, followed by house staff training, chief residency, and fellowship training in endocrinology, all here at the University of Washington. During his time on faculty, Dr. Anawalt has demonstrated true excellence in clinical care, medical education, and clinically based research. He was initially based at the VA Puget Sound Healthcare System, where he practiced in both the general internal medicine and endocrinology subspecialty clinics. Since his transition to the University of Washington Medical Center, he regularly staffs patients in the Endocrine and Diabetes Care Center at Roosevelt and serves on the inpatient endocrinology consult service. He is regarded as an exceptional clinician and has been honored in many physician-based surveys of local and national top doctors. Dr. Anawalt has also received numerous teaching awards, including the Beeson Award, the UW Endocrine Fellows Teaching Award, and the Turk Award. Dr. Anawalt's research is clinically based and is focused on male hypogonadism, testosterone replacement, male infertility, and male hormonal contraception, and he has published very extensively in these areas. But more relevant to today's discussion, Dr. Anawalt also has an interest in androgenic anabolic steroid use in athletes and is a committee member on the Therapeutics Use Exemption for the U.S. Antidoping Agency. And so please join me in welcoming Dr. Anawalt as he presents Performance Enhancing Drugs, Passport to Play.
So for me, this is a special Grand Rounds. 20 years ago, I gave my first Grand Rounds here. I was terrified. For those of you who are junior faculty of not giving Grand Rounds, probably the most terrifying experience is to speak in front of a group that you hope are your friends. You want to impress, you want to do a good job, you want to entertain. This is special Grand Rounds because, not because it's 20 years, almost to the day that I gave my first Grand Rounds. This is my 5th or 6th. I'm trying to catch up to Jan's 20 some odd Grand Rounds or whatever he did. But it's the last Grand Rounds that I'll be giving with Dr. Bremner as my chair. And you'll get a little flavor of the meetings we had weekly with the fellows, dating back now over 25 years. We had a lot of laughs. Dr. Bremner sold me on the idea of going into endocrinology because he said, it's a lot of fun, you get to travel, you get to go to interesting places, drink port, which I did regularly with Bill on various occasions. You get to laugh, and there's a lot of fun in medicine. And he also said, all my fellows get one of these. And that sold me. Actually, the most expeditious transport I got through, everybody knows what these are, right? Okay, good. I'm not going to explain, although I did have to explain these when I went through TSA a number of years ago. And I offered to demonstrate, and I got quickly shown through TSA, so it's actually been kind of handy. So with that backdrop here, my disclosures, I have no financial disclosures other than I'm about to send my first of 3 daughters to college. As Ryan alluded to, I'm a consultant for the Therapeutic Use Exemption Committee. I have done so for about 14 years for the U.S. Anti-Doping Agency, so I review the applications by athletes for using various drugs that have been banned for performance enhancement, and they claim they have a medical need for it. In the last 5 or 6 years, we've had a dramatic increase in old people asking for testosterone and various performance-enhancing drugs, therapeutic use exemptions, and that's because now we're seeing 40, 50, 60-year-old men who are performing in masters events who are asking for these things. So there's been a very interesting shift in the demographics. At this point, I'm a non-user of a performance-enhancing drug, only coffee. So this is actually where it all began. The history of performance-enhancing drugs dates back to, I'm getting an echo here, I think I've got both the microphone and the mic on. In the 1950s, I'll push it away. In the 1950s, the Russians, Americans, East Germans were aided and abetted by German and Dutch chemists who were developing various derivatives of testosterone. And they experimented with weightlifters primarily. It was actually Dr. Ziegler, who was a physician for the American weightlifting team, that was the first to experiment officially with giving a diagonal, which is a synthetic form of testosterone, and a little pink pill. He ran this experiment, and the athletes were noticing dramatic increases in their weightlifting, so they stopped taking 1, they took 2, then 4, and then 8, and we were off to the races, because that's really the precedent for the vast amounts of anabolic androgenic steroids that athletes use. In 1967, there was a ban on anabolic androgenic steroids and other drugs thought to be performance enhancing, and they tested for the first time in 1968. And Hans-Gunnar Ligenwald was the first athlete to be banned for doping at the Olympics. He was a pentathlete. He tested positive for alcohol after he drank 3 beers before he won the bronze medal in the pentathlon. It did take us 50 years. Finally, last year, reluctantly, the World Anti-Doping Association, in agreement with the United States Anti-Doping Association, agreed that alcohol is not a performance-enhancing drug and has officially removed it from the banned list after 50 years. This is a picture of what really started the whole thing. In 1988, Ben Johnson shattered the 100-meter record. He took the time down from 9.93 seconds to 9.79. In the background, you see Carl Lewis, who is his arch rival, who had dominated him for years. And in this race, you see him looking back and actually lost probably a little bit of time in his taunting gesture over Carl Lewis. He subsequently tested positive for anabolic androgenic steroids. And for decades, the scientific community had doubted the verity of the claim that these drugs actually appreciably increased your athletic performance. But the athletes didn't believe the scientists and continued to use them. It took another decade for finally a paper to come out in the New England Journal of Medicine by one of Dr. Brimmer's colleagues, Dr. Basine. He did a study that I like to think of as the couch potato versus exercise versus testosterone study. He had 4 different groups of bodybuilders, weightlifters that agreed to perform in this study. They had supervised sedentary activity for 10 weeks. So they were actually observed and they were forced to be sedentary and not do weightlifting. Another group continued to do weightlifting, and a third group did weightlifting with testosterone and another group without. And so what you see here, they were given testosterone at a dosage of about 8 times physiologic replacement dosage. All I'm going to show you is the data for bench pressing here. The couch potatoes, there was no increase. The couch potatoes plus testosterone increased their bench press by 20 pounds. So those of you who lift weights, just sitting on the couch and taking testosterone was enough to appreciably increase your bench press. Weightlifting was the same as sitting on the couch and taking testosterone, and then you saw an augmentation of the effects of weightlifting with testosterone. So finally, decades after the athletes had already known the truth, the medical community accepted the fact that these were truly performance-enhancing drugs. In the mid-1990s, there's a widely quoted Goldman Survey. It's a very interesting survey. This was published in that reputable medical journal, Sports Illustrated. Would you take a banned drug with a guarantee that you would not get caught and you will win an Olympic medal? So he interviewed nearly 200 elite athletes, and the answer to this question was 195 out of 198 elite athletes said, why, yes, we would. Would you take a banned drug with a guarantee that you will not get caught, you will win every competition for 5 years, and then die from adverse effects of the drugs? More than 50% said, why, yes, we would do so. So this has been quoted for years as this dramatic evidence of how much athletes are willing to do in order to compete successfully, win gold medals. And one of the things you can do is just ask the question, can you name a silver medalist? We don't remember those people who finished second. And the difference between first and second can be a couple of pounds, it can be an inch. It's these very, very tiny increments. So they're looking for any possible advantage. Now, one of my jobs in grand rounds is to present all perspectives, give you a little balance. There's been a great deal of incredulity about the Goldman Survey. This, for those of you who don't recognize this, is Mount Rushmore. It's an icon in the United States. This is the American perspective of Mount Rushmore, and this is the Canadian perspective. So there are more than one ways to look at this, and there were skeptics about the Goldman Survey, so a bunch of Aussies got together and did a study. This is the Konnor Survey. And let me tell you, the inducement for participating in the survey, they did this at track meets, and every athlete that agreed to complete the survey got a sealed Gatorade bottle. So So they got a bottle of Gatorade that was sealed as their compensation. So they found 109 elite Aussie athletes who were highly motivated by that. And they asked this question: would you take an undetectable illegal performance-enhancing substance with a guarantee you will win an Olympic gold medal, but it will kill you in 5 years? A very similar question to the Goldman Survey. 2 out of the 109 elite Aussie athletes said yes. So one conclusion is that the Aussies are a little less motivated to win, the times are different, that Goldman had a bias built into his survey. Then they asked an additional question: would you take an undetectable legal performance-enhancing substance with a guarantee you will win an Olympic gold medal, but it will kill you in 5 years? 6 of them said, well, hell, if it's legal, I don't mind dying, but as long as it's legal and I don't have to break a law, I'll take the drug and win a bunch of medals and die in 5 years. So actually 6% of them said yes. And then the last question they were asked was, would you take an undetectable illegal performance-enhancing substance with a guarantee you'll win an Olympic gold medal? And 12% of them said yes. So the numbers are not as dramatic as the Goldman Survey, but still, there's a number of people out there that are competitive athletes that are willing to die as long as they're not breaking the law. And actually, I don't think that's quite true. I think they're getting more honest as the visible stakes get lower. So the epidemiology of performance-enhancing drugs, these are called PEDs. That's the acronym that's commonly bantered about. 1 to 2% will have a positive test in WADA, World Anti-Doping Associated sponsored events and monitored events, so very low positive test rates. Of those 1 or 2%, there's about 10,000 tests done a year. There's only 20 or 40 that are considered to be true anti-doping violations. So there's this very complicated process of adjudication where they try to rule out false positives and so forth, and they arrive at only about 20 to 40 positive anti-doping violations each year. So that suggests that the rate of use of these drugs is very low. Most of these anti-doping rule violations are unintentional. The athlete doesn't or claims that he or she doesn't know that they're taking it. But we've got better data than this. So there's a technique called randomized response technique. And what you do with this technique is you have your subject roll a die or pull a card out of a deck. So you know exactly, it's a random, but you know exactly how many random events can occur. And then they give the correct answer to a question, or they give a random incorrect answer. So, and then they go back, they do a calculation going backwards. They know how often a random wrong answer will occur, and so they can extract that from the data and then come up with the number of times that people have given their real answers. And the reason that's valuable is that as a subject, there is no way to connect your answer with the survey. So you really truly are protected in terms of your anonymity. So when you do these sorts of surveys, you get a range of statistics. You don't get a nice specific number, but you get a much more valid answer. And with these surveys, what they found was that 26 to 39% of German elite athletes used performance-enhancing drugs ever. Up to 50% used these drugs in the last year. Elite junior athletes, not so much, up to about 11%. These are Dutch athletes. And then finally, members of Dutch fitness clubs, up to a quarter of them used performance-enhancing drugs in the last year. So there's a real discordance between what people are willing to report they've used and the positive test results in the World Anti-Doping Association. So there's an alphabet soup of governance. I've mentioned WADA and USADA. Many countries have their own anti-doping association. And then finally, in the United States, we have the NCAA, which has its own set of arcane rules. So this has been the code for the World Anti-Doping Association. It has been embraced by all of the national anti-doping associations around the world. If you meet any of the 2 following criteria, you are in violation of the WADA prohibited list. So if you're using a drug that has the potential to enhance sports performance, if there's an actual or potential health risk, or finally, and this is the softest one of them, if the use violates the spirit of sport. Now, I say that with a little bit of irony and sarcasm. For those of you who are following, for instance, the Nike elite athletes, they go up to 10,000 feet, or they go into pressurized tents to enhance their athletic endeavors. And I'm not quite certain that's commensurate with the spirit of sport. But nonetheless, that's acceptable, and these drugs are not. So the banned categories, the anabolic agents, those derivatives that are similar to testosterone, there are also banned methods. These are never. So you're never to use genetic alterations, you're never to use blood doping, and you're never to use anabolic agents. There are other substances that you can use, but not in competition. So for instance, you can use narcotics, but you can't use it while you're in competition. You can use glucocorticoids out of competition, but not in competition. And then for certain sports, you can use beta blockers, but not in competition. For example, in archery or the biathlon where you're shooting guns, beta blockers have been prohibited because they help prevent tremor. And then alcohol was banned up until 2018. They managed to actually narrow it down to karate, archery, and sports with motors. That all seemed like a good idea. And then they lost all sense last year and actually took it all out. So the anabolic agents include testosterone. They also include aromatase inhibitors, which block the conversion of testosterone to estrogen and increase testosterone both by that blockade and also by increasing endogenous testosterone secretion. Selective estrogen receptor modulators, substances like raloxifene, tamoxifen, and more commonly in men, clomiphene, can raise testosterone concentrations, and they've been banned. Insulin and PPAR gamma agonists, so agents that are used to treat diabetes, have been banned. Peptides, erythropoietin growth hormone, and HCG. HCG is a gonadotropin, which increases testosterone production in men. Beta-2 agonists are considered anabolic agents, and so the only two that you can take are salbutamol and formoterol. And then finally, just last week, you all learned that diuretics are banned. They're masking agents, and so the principle there, the second baseman for the Mariners has been kicked out of baseball for 80 games for testing positive for furosemide. And the concept there is you don't want to have something that they're using to dilute their urine. So we'll evade detection by taking a large dose of diuretic and then produce very dilute urine, and you can't detect the compound that they're actually using to as performance enhancement. So in competition, the non-anabolic androgenetic steroids, all stimulants, including pseudoephedrine, there's actually an upper limit for which you can use. Ritalin is also banned, so we've had a number of therapeutic use exemptions for Ritalin. Narcotics are banned in competition with the exception of the three below. You can use cannabinoids out of competition, but not in competition. I'm not sure exactly how performance enhancing that is, but it may make you feel better about finishing second. And you cannot use glucocorticoids in competition. And then finally, as we described, beta blockers are banned in certain sports, including, fortunately, darts. Prohibited methods, IV fluids, again, for the same reason, you don't want to dilute out substances, and then they're also considered a form of volume repletion that's banned in competition. Proteases, manipulation of blood and blood components, gene doping, and the use of normal or genetically modified cells. So in the 2008 list, there's also monitoring. So there are drugs that they're monitoring, but they're not officially banned. They're actually trying to see how often they're used and whether or not they should act. And there's no penalty if there's a positive test. So interestingly, caffeine is one of those substances. Nicotine, you're not supposed to smoke or wear a patch. Phenylephrine, pseudoephedrine, and then a couple of narcotics. And out of competition, as I mentioned, glucocorticoids. So I'm going to go through the United States anti-doping testing for androgen use and for other performance-enhancing drugs. This is the method that's used worldwide. There are very strict criteria for obtaining urine or blood samples. You have to have your collection method observed by an outside observer. And sorry, I'm getting a text here. Oh, thank you. My daughter just said, crush the talk. So that's another difference from 20 years ago. So strict United States anti-doping criteria for laboratories. They measure testosterone and epitestosterone ratio, which I'll review in a minute. They have to use mass spectrometry, which is not a commonly used method in commercial labs, but this is the most accurate way of measuring steroid hormones. And then they do something called carbon isotope ratio testing, which I'll also describe in a minute. And then I want to introduce this concept of the biological passport, which is come into much more common use in the last couple of years. And this is the idea that if you had a baseline value for a man or a woman at baseline, and then you follow them longitudinally, you can look for changes to detect that they're using some performance-enhancing drug. So with testosterone doping, you look at the testosterone-epitestosterone ratio. Epitestosterone is secreted by the same cells that make testosterone, but it's biologically inactive. There's no conversion between testosterone and epitestosterone. Epitestosterone production is much less than testosterone, but it turns out the urinary excretion is much, much higher. So as a result, you get a ratio that's about 1-to-1 or 2-to-1 in the urine in normal men. And if you have a testosterone-epitestosterone ratio that exceeds 4, that's considered suspicious. Most men will be under 3. This is actually a distribution of more than 4,000 samples of male athletes in an accredited laboratory looking at the testosterone-epitestosterone ratio. You can see here I've drawn in, well, maybe I drew in a line. This is the difference going from a MAC to a PC. Well, there's a little line that I drew, and it's going to fly by you at 3. You can see everybody's to the left of it except for a few athletes. There are some false positives and negatives, so there's some genetic variants that have naturally much, much lower epitestosterone concentrations, about 10% of normal. And those men will never test positive, or virtually never, when they're taking testosterone. And so they've had to make accommodations for that, look at baseline levels, and then use that individual's baseline in order to try to detect the use of testosterone. And then athletes are smart, and they work with smart people. So they're now taking testosterone and epitestosterone to preserve the ratio. The stability of the testosterone-epitestosterone ratio is actually pretty impressive. It's quite constant. Well, you saw that line fly by quickly. There was a purple line there. You can see it's 2 across the entire 3 weeks that the athlete is tested daily. Finally, there's this interesting confirmation test that's used. So if an athlete tests positive with a testosterone-epitestosterone ratio, then they look at the carbon-13, carbon-12 ratio of testosterone. And it turns out that plants such as maize, millet, sugarcane, and pineapple have a high amount of carbon-13. They selectively take up carbon-13 compared to carbon-12. Whereas synthetic testosterone is derived from yams and soy that are low in carbon-13. So you can look at the ratio of carbon-13 to carbon-12 and see whether or not it's their own endogenous testosterone or if they're taking an exogenous source from, say, a soy or a yam derivative. And you use cholesterol, their serum cholesterol, to standardize this. So it's a very clever test. So this is the idea of the passport, and I'm going to go over this here. Oh, sorry about that. I'm getting a call here. Can you give me just a second here? Real? Yeah, this Brad. Yep. Right now? Really? Okay, well, I'm giving a talk. Okay. Sorry, you're making me nervous, John. All right. Okay. Will the results be ready by Sunday? Because I've got this dad-daughter 5K. All right. So there has to be observed collection of baseline urine, and in fact, what I just demonstrated for my own competition, I hope I actually pass, is it's exactly this. The athlete is called, they're told they have an hour to be ready, they have to be located, and then somebody comes and observes the collection of the sample, and they whisk it away. So what happens is they get a baseline urine, they have secure transportation to lab, so we'll watch John.
If they have this back.
Oh, good. I meant to give you a towel to clean the top off. So you measure the markers of anabolic androgenetic steroid use. Then the next step is to enter the values into a secure database. And then finally, there's a review by an expert as to whether further testing is needed. So this is the initial process for establishing baseline values for the passport. If a single expert considers the passport data normal, then a cycle of continual monitoring begins. Now, I just want to go over this one more time because I'm going to show you the pitfalls. It sounds actually wonderful, scientific, systematic. The first one is the observed collection of baseline urine. So if you're an elite athlete, you actually don't enter into these programs until you become elite. So you can have 10, 15 years before you get to the point where they're going to test you for your baseline sample. And if you begin abusing prior to that baseline sample, you have set your baseline at the abuse baseline. And so that is a particular problem they haven't solved. Secure transportation to the lab is a problem. John Amory was the expert witness for the Floyd Landis trial, and there were issues with secure transportation of the sample to the lab. There was some suggestion there might have been tampering. Measurement of the anabolic androgenic steroid markers in the lab. There's also an opportunity for unscrupulous lab people to tamper with the sample. And then entry of the values into secure database. That requires that somebody accurately enter the data and that there isn't somebody that's actually actively putting in bad data. Turns out this step here, review whether further testing is needed, is actually the best of all the steps. If the single expert doesn't think that the baseline data are accurate, then there's a consultation with a panel. So there's an entire panel that reviews this. So this is actually probably the best, and albeit the most subjective of the entire process. After they've gone through this baseline collection, then they get observed collection of random urine samples over the course of months to years. Again, you have the transportation to the lab, measurement of anabolic androgenic steroid markers, entry of values into secure database, and then longitudinal comparison by expert or experts if there is a value that seems awry. So this just proceeds in a circular fashion. There's notification again, it goes round and round and round. So there are a number of athletes now entered into this program, and it sounds terrific, but it does have its problems. So methods of avoiding detection, we talked about IV fluids and diuretics. They can use masking agents. So for instance, probenecid decreases the excretion of androgens and androgen metabolites. So that's a banned substance. So I don't see my colleagues from rheumatology, but who would know that a treatment for gout would also be used by athletes to prevent detection of anabolic androgenic steroids. They use the concept of pharmacodynamics versus pharmacokinetics. So if you do multiple injections of a short-acting drug like testosterone, you do IV injections, it has a very short half-life in the blood, but its biological half-life and its activity in the body is much longer. So that's in fact one of the ways that the cyclists were avoiding detection. They were dripping testosterone at night, turning it off, and then the testosterone was gone by morning and they wouldn't test positive. And then the last one is actually substitution of someone else's urine, which is why we're all watching John carefully as he leaves. This is a picture of Marion Jones. For those of you who don't know, she looks kind of cherubic. She's got subcutaneous fat on her face. And then after she tested positive for anabolic androgenic steroids a few years later, she admitted that she hadn't used them initially, and then she did. You can see the morphologic changes. They lose their subcutaneous fat. So the question is really, how do anabolic androgenic steroids increase muscle and strength? There are direct anabolic effects of androgens to increase muscle mass and muscle strength. But importantly and poorly recognized is the mental effects of androgenic anabolic steroids. They decrease fatigue and pain. And so one of their primary effects is, for those of you who've exercised vigorously and the next day you feel kind of logy and tired, the anabolic androgenic steroids help you overcome that and allow you to go back to beat up your body again. This acts through GABA receptors in the forebrain, and I'm just going to show you data that's now about 10 years old, but it's still some of the best data in the field. In the forebrain, there are cells that have androgen and estrogen receptors and GABAergic neurons, and there is an interaction between anabolic androgenic steroids and these neurons. So they interact with the intranuclear cell, the intranuclear receptors for androgens and for estrogens. And then there's a transcription effect, and they have an increase in GABA receptors. And then there's an effect directly on the GABA receptors to open them up, and now the GABAergic neurons release GABA, and you get activation of these neurons, and you get then these effects of androgens on mood. There's also a non-genomic effect or a non-transcriptional effect. So there appears to be a sex steroid receptor in the membrane. So this is a non-nuclear membrane. And this has direct effects on the GABAergic receptor. So we've learned a lot about the biology of androgenic anabolic steroids, courtesy of the athletes. The last thing I'll comment on here is that if you chronically take anabolic androgen steroids, this is all like cocaine. You get downregulation of the system, and so when you come off of these drugs, they'll report a withdrawal syndrome, and they're cranky, they're tired, depressed, and that can last for months. This is a picture of my family. So, what are the side effects of androgen anabolic steroids? Acne. In men, there can be increase in breast tissue because of the conversion of testosterone to estrogen. And in women, the anti-proliferative effects of androgens can reduce breast mass, so it's opposite. The oral formulations of androgens are alkylated, and the process of alkylating androgens causes hepatotoxic compounds. So if you have an oral formulation, they're associated with hepatopathy. And then there's some long-term hormonal effects, specifically infertility, which is generally reversible. There's a lot of research now being done on the effects of anabolic androgen steroids in the adolescent brain. And recall that for men, adolescence, at least in the brain, doesn't stop until around 25 or 30. So for these elite athletes who are taking anabolic androgen steroids between the onset of puberty and 25 or 30, they're having important effects on their brain development. And then this whole concept of steroid rage, which does occur, but only at really prodigious doses of anabolic androgen steroids. Just a quick review of the physiology of testosterone. It's converted to estradiol by this enzyme called aromatase. Estradiol is crucial for normal bone. It's also crucial for normal sexual function. And finally, estradiol has an important role in regulating body fat. It turns out that in the absence of estradiol, body fat accumulates. The importance of this is many athletes and many men are asking for testosterone plus an aromatase inhibitor. And the reason why they're asking for that is they want to prevent the onset or development of gynecomastia. But what they're doing is they're preventing the positive effects on the bone, on sexual function, and on fat. And then many of these anabolic androgenic steroids are not aromatizable. They don't convert to an estradiol-like compound. So the cardiovascular effects of androgens, I want to make one important distinction here. There's a difference between the drugs I'm talking about. And anabolic androgenic steroids that are used for abuse, for pharmacologic purposes, and testosterone therapy for hypogonadism. So in anabolic steroid abuse, based on cohort studies, we know that there's dramatic declines in HDL cholesterol, particularly if they're administered orally. There's a significant rise in blood pressure, and there's an increase in inflammatory markers, including CRP. This is not true for testosterone therapy in replacement doses for hypogonadism. We have a number of, it's impossible to do randomized controlled trials in these patients. So what we have is case series and case control. There's increased cardiovascular events, including myocardial infarction, heart failure, and cerebrovascular accidents or strokes. There was a recent case control series and over 200 anabolic androgenic steroid abusers that used it for more than 2 years. There was increased coronary artery disease, and there was increased LV dysfunction, both diastolic and systolic. So what's the reversibility of these side effects? Well, there's no good longitudinal follow-up studies, so we're really based on cross-sectional studies and relatively weak evidence. This cross-sectional study, a small number of anabolic androgenic steroid abusers versus X or reformed anabolic androgenic steroid abusers. There was 15 X abusers who reported that their mean dosage was 10 times physiologic for at least 26 weeks a year for 9 years. So they were using huge doses of testosterone intermittently for 9 years. And this is actually a common practice in the community that uses anabolic androgenic steroids. They'll use high doses and then they'll stop, or they will use multiple different agents called stacking. And the whole premise here is that somehow that's safer than continually using a high dose of a single substance. They had quit for at least 12 months. Many of them had quit for 2 years. What they found was that 13 of the 15 X abusers had testosterone concentration so that were in the lowest 20% of the normal range, which is, in terms of percentages, a much higher proportion than you would expect based on random chance. And 2 of the 15 X abusers had testosterone below the normal range, which suggests that there may be a very long period of time for recovery after chronic use of very high dosages. Their gonadotropins were normal, suggesting that the pituitary had at least recovered. But the lipids, hematocrit, and chemistries had all normalized. Some of them had abnormalities in their liver function. So the slowly resolving effects of anabolic androgen steroids include gonadal axis suppression, and then depressed mood is another one that may persist for months or even a year or two. These are data showing the recovery of sperm production after discontinuation of anabolic androgenic steroids. And the important thing here is, first, this green line shows you the lower limit of normal, which is 13 million. And you can see that it takes up to a year or even 2 years to recover sperm production to normal levels. So after taking anabolic androgenic steroids, these men may be infertile for up to 3 years. So the laboratory abnormalities we see are suppression of LH and FSH. Their intratesticular testosterone and their serum testosterone are low, and they have decreased spermatogenesis, often down to 0. The conventional wisdom is you don't treat these men, you simply ask them to stop taking their anabolic androgenic steroids and they will recover. Most of them recover within a year, but as I mentioned, many take up to 2 to 3 years. And there appears to be a much longer recovery the longer you take the steroids and the higher the dosages. I have modulated my approach over time, so this is one of the things about either getting wiser or more relaxed or just beaten up. I used to take a very firm line that I would not treat these men. They just needed to stop. It turns out, though, that many of these men will just leave and never come back, and they're highly frustrated. They will find their own therapies, and so I've taken slightly different approaches. For men that are seeking fertility and are highly motivated and have a spouse that's highly motivated, sometimes what we use is gonadotropin therapy, so we give the pituitary hormones to try to expedite the process, or we give clomiphene. And so that can be another way of expediting the process of recovery of the gonadal axis and improving fertility. The one caveat about clomiphene is we don't have long-term safety data for men, and there is a risk that they may have venous thrombosis while taking the selective estrogen receptor modulator. Just want to shift gears here and talk briefly about growth hormone, which has become the rage now as an additional anabolic compound to use. It's the latest fad. The rationale is partly it makes you look ripped. For those of you who don't have teenagers, that means you don't have an ounce of fat on your abdomen. And they think that it increases athletic performance. There is a significant increase in use in young elite athletes. What we know from growth hormone treatment of men and women with clear-cut growth hormone deficiency associated with pituitary disease is that growth hormone replacement will decrease fat mass, increases bone mass, and increases exercise capacity. It also increases quality of life. But the lower, the less growth hormone deficiency you have, so the less severe it is, the less the effect. And so when you get to the point of being normal, the experts think that if you give growth hormone, it has no effect at all. So it's all about replacement of deficiency, but the greatest effect seen in those patients with severe growth hormone deficiency. Now remember, turn the clock back, 1988. The athlete said it works, the scientist said it didn't. So there are a little bit of data on this. In 2010, there was a study of sprinters with growth hormone, and there was a 4% increase in sprint capacity in both men and women. So this was measured in hundreds of seconds in very short distances. But remember, races are won and lost in hundreds of seconds. And it was 8% when combined with testosterone therapy. So they were additive. So the athletes keep using growth hormone and other agents. They cycle, they stack, and they pyramid, meaning they go on and off. They take multiple things, and they do with both growth hormone and testosterone derivatives. And athletes are measuring their effect in millimeters. We're getting far more requests now for therapeutic use exemptions for growth hormone. So again, reflecting the trend of use. The last thing I want to introduce to you is something that happened about 10, 12 years ago. I caught wind of this. A very famous former NFL quarterback who is about 6'5", had a son that was a terrific prospect at about age 13, already being looked at as a potential starting quarterback in college. Colleges were interested in him. His projected height, though, was 6'1". Not big enough, and his hands were a little smaller than Dad's. So the question that this quarterback father had was, can we increase his height and his hand size and strength? So went to an endocrinologist, said, can we delay puberty with this compound that acts against the pituitary, give growth hormone so they keep growing, because what happens with testosterone is it closes the epiphyses of the bones. So when people go through a growth spurt, the testosterone or estrogen gives you a little boost, you grow for an inch or two, but it closes the growth plate where growth is occurring, and you stop growing. So if you stop that, you can keep on growing. And then you give anabolic androgenic steroids. So there are some unscrupulous physicians who are aiding and abetting this sort of thing. Just quickly, the conclusions for ordinary people, of which I'm included. Diet and exercise are the best performance enhancers. Testosterone is beneficial for male hypogonadism. But I just want to remind you that testosterone can be used pharmacologically, not just for physiologic replacement, and the benefits and risks are unclear. And any form of exogenous testosterone, whether for replacement therapy or for abuse, causes a reversible decline in sperm and male fertility. So the conclusions for athletes, anabolic androgenic steroids are clearly performance-enhancing drugs. That testosterone for male hypogonadism is not the same as anabolic androgenic steroid abuse, nor is the attempt by Dr. Page and Dr. Amory and Dr. Bremner to create a male contraceptive based on testosterone, is that tantamount to anabolic androgenic steroids. So don't actually confuse the two. This is not abuse of a steroid. This is using typical physiologic replacement doses. Growth hormone and IGF-1, the scientific community doesn't regard them as performance-enhancing drugs, but the athletes do. My money is on the athletes. There are lots of ways to cheat, and there are lots of ways to get caught. And it's a race. Right now, the data suggests that the athletes continue to be about a half a step ahead of the experts. Dr. Amory takes a more cheerful view of this and says, no, we're keeping up with them. But it's hard to know. So this is me skating on thin ice. I have one more comment I want to make here. This is data on testosterone prescriptions in the United States. On the far left, you see testosterone testing, and on the far right, you see testosterone initiation. And on the top, you see that testosterone testing initiation increased dramatically about the time that testosterone gel was developed. So when we went from having an injectable formulation that hurt and was inconvenient to a gel that could be applied daily and didn't hurt, there was a dramatic increase in the prescription of testosterone. It also corresponded to the low T syndrome, which was developed by a marketing firm for the pharmaceutical company that made testosterone gel. And it's one of the most successful campaigns in advertising history. It's made billions and billions of dollars for the industry that makes testosterone. On the bottom is the Brits, and they keep a stiff upper lip, and there has been no change over the same time period. So either they're more manly or they have more practical approach to testosterone therapy. But the point I bring up here is that there has been a widespread concern around the world about giving testosterone at replacement dosages to men. And I want to make a very, very important distinction between the talk that is focused on anabolic androgenic steroids used at prodigious doses and using adulterated compounds, which clearly have some significant health effects, and the use of testosterone in conventional doses for treatment of hypogonadism. Now, the great unknown between the two of those is what about using a dose of testosterone that is slightly superphysiologic, so now you're using it for pharmacologic purposes, or you're giving it to a man whose testosterone is at the lower limit of normal and you're going to bring it higher in the normal range. Again, a pharmacologic intervention. So that's the area that the researchers are grappling with and trying to figure out whether the benefits exceed the risks. But bear in mind that the athletes are right, that there is a dose-dependent effect. There is, even in the clinical trials that have been done to date, there is an effect on muscle mass and strength. The question is that worth the risk? So I don't know, but I don't want to confuse the two. And they have been conflated in the scientific community and in the general public, and it's created a lot of confusion. So finally, normally I would show one more funny slide. I do have another funny slide, But I want to change things up here a little bit today. I mentioned this is a special grand rounds for me. This is my 5th one, 20 years. My last one with Dr. Bremner as the chair, sitting right there. And I want to just tell you a little bit about our Tuesday meetings. So Dr. Bremner, no, it's not going to go downhill, Dr. Bremner. The next time it'll go downhill. No, I just want to actually talk a little bit about Dr. Bremner. So he's just a few years younger than my dad was, and they're both native Washingtonians. And if you spend any time with either one of them, they are rich with, I think, aphorisms and sayings that are common just to the Northwest. Things like, you don't want to shingle past the eaves of the roof, and it's a lead pipe cinch, and all these little funny aphorisms that you're sitting there thinking, let me think about, oh, I get that. You don't want to over shingle the roof. Okay. So Dr. Bremner will drop all those things. But the key to Dr. Bremner was when I met him, he shamelessly recruited me into endocrinology and academics because it was fun. And it reminds me of what my father said. I'm quite certain my dad would say the same thing about Dr. Bremner. My dad said, I had so much fun at work. I never had a day of work. It was all play. I'm quite certain he would look at Dr. Bremner and say, you never worked an honest day in your life. So what I'd like to do is recognize that in this whole era of performance-enhancing drugs, Dr. Bremner's done this for 20 plus years. I think that's a record. I know it's a record at the University of Washington. It's got to be in the upper echelon and in all of department chair history across the nation. So let's celebrate somebody who's done a terrific job for more than 20 years. And that should be venerated far more than winning a gold medal in the Olympics. So thank you, Dr. Bremner.